Thanks so much, Shelby. I'm so glad to be here with y'all tonight. I'm Dr. Reem Sabouni. I'm here at Houston Fertility Institute in the Kingwood office, as Shelby said. And so I'm really excited to share with you a topic on the menstrual cycle and ovulation. So this is near and dear because this is basically the bread and butter of what it is we do. And I think that for a lot of patients, understanding this process a little bit more can give you a little bit more understanding about your treatment and what your body is naturally doing or supposed to do in order to get that understanding. So let's go ahead and get rocking and rolling. And just as a reminder, just like Shelby said, we have a question and answer and we have a chat function available. So my favorite part of this presentation is to be able to answer any burning questions that you'll have, especially as it pertains to the menstrual cycle and ovulation. All right, so let's get rocking and rolling. So this lecture is actually a lecture that I give to medical students and to OBGYN residents that obviously I distilled down a little bit, so we're not going to be geeking out together completely. It's a really fun presentation, and so this is what I actually give to medical students and OBGYN residents, okay? So let's get rocking and rolling. All right, so let's talk about the menstrual cycle. So the menstrual cycle is actually a very complex process that involves different organ systems. So it involves your ovaries, it involves your uterus, and it also involves your hypothalamic pituitary ovarian axis. So it's not just hormones, it's also involving two different organ systems as well in your body. So essentially what happens is your follicular development, or as a follicle grows, it starts secreting more and more hormones like estrogen, which basically is what we use to build the lining of the uterus. And as the estrogen levels get higher and higher, it causes a surge in our LH, which is a hormone that our central in our brain gets secreted, which causes ovulation to happen. So that causes the release of the egg. And then what happens is then the follicle then shifts function. So what remains of the follicle becomes a corpus luteum, which its job then becomes to secrete progesterone, which prepares the lining for implantation. And then if no pregnancy occurs, then that stops functioning. So you have a drop of your progesterone, and then you get a drop in your estrogen, and then that leads to a rise in your FSH, or your follicle stimulating hormone, which causes that process to kind of go restart again. So that's kind of like our eagle eye view of the menstrual cycle, but let's tackle it in a little bit more detail and how it pertains to fertility. So the most important thing to think about is, first of all, let's talk about ovarian reserve. So we as women were born with a set number of eggs that we'll ever have in our life, and we slowly lose them over time. So when we're about 16 to 20 weeks in utero, meaning we're still in our mom's stomach, we have about 6 to 7 million eggs. That's the maximum number we'll ever have. By the time we're born, that number is usually down to about 1 to 2 million. And by the time we hit puberty, we've lost even more. So we're down to like 300 to 500,000. Okay. So we're constantly losing eggs over time, and there's nothing that we can really do to stop that process. So during our reproductive life, during the average reproductive life, you'll ovulate about 400 to 500 of those eggs that you've had since before you were born. And then by the time you hit menopause, it's not that you would have no eggs, but you'd be down to about 1,000 eggs. And of those eggs are not really functional for the purposes of trying to get pregnant. So when we think about it as it pertains to being able to have children, so by the time, so your optimal fertility is, when you're in your late teens, early 20s, right? By the time you hit 31, you're starting to notice a decrease in the fertility, and that takes a really sharp downturn at the age of 37. And really in your early 40s is really when you're starting to see an end in fertility. And it's not because the fact that you don't have the eggs, but the eggs that you have, the quality is a little bit compromised. So it becomes kind of a little bit of a quality quantity issue when you think about eggs, right? So these are two separate things. So to get a little bit more idea and detail, this is kind of a graph that you can think about that illustrates the whole quantity quality issue. So one of the things that you see is that you definitely see a drop off in fertility as it pertains to the quantity of the eggs that you have remaining. But when you think about quality of the eggs, that's like, for example, the likelihood that you would have a chromosomally normal child, right? So as we get older, we have a higher likelihood of having a child that may be chromosomally abnormal. So that's, and one of the number one causes of a miscarriage or an abortion is chromosomal abnormalities. So really here in this graph, you see it represented beautifully, because as we get older, the likelihood of having a spontaneous abortion increases significantly. And a lot of that has to do with the fact that as we get older, the quality of our eggs are just not there, meaning that the likelihood of the child being chromosomally normal, and a way that you can kind of think about it is that the longer that you have the eggs, the more time that it has to chromosomally rearrange. So the likelihood that you can get a chromosomally normal child will be a little bit more diminished or harder to achieve. All right, so I'll leave that now. I know that's a little bit of a depressing topic, but it's a really important topic to understand because this might be something that you might be facing. So when we are born and we have these follicles, and we have these follicles from before we're born, they're really resting in us as primordial follicles, meaning these are at a metabolically kind of an inactive state. They're not really doing much. Well, there's something that triggers them to activate, and we don't quite know scientifically what are the exact things that happen to trigger these follicles that we've had since before we're born to finally kind of start waking up. But we know that the process of a follicle progressing from a primordial follicle to a pre-ovulatory follicle takes about 85 days. So why is that important? Well, that means that if we're going to be doing a medication, if we're going to be doing something to try to improve egg quality, then really like doing something like DHEA or coenzyme Q10, supplements that we would recommend for patients that potentially are older than the age of 35 or that we have concern might have compromised ovarian quality, then really you should be starting these treatments 2 to 3 months prior to the IVF treatment that you're hoping to undergo, so that it has a chance of really impacting the follicle from that cycle. So from the progression from a primordial follicle, which is kind of like, think of that as your resting inactive follicle that you've had since birth, to becoming activated, becoming a preantral follicle, which you see when you do your baseline ultrasounds for your antral follicular count, to becoming an antral follicle and then a pre-ovulatory follicle getting ready to ovulate, it takes about 85 days. So 85 days is important to think about if you're doing treatments like DHEA or coenzyme Q10. So this is what it kind of looks on ultrasound when you're looking at follicular maturation. So remember how we talked about previously these preantral follicles and the antral follicles. So these antral follicles here we can see on ultrasound, and this is what it looks like. So they're basically measure anywhere from 2 to 10 millimeters in size. And so when we count them, when you come in for your baseline ultrasound on day 3 of your menstrual cycle, and we count these, this is also a surrogate for us of your ovarian reserve. So this is what it looks like in size in comparison to if you're looking at a woman who's about to ovulate or release the egg. This is what a pre-ovulatory follicle looks like. It's usually measures about 17 millimeters or greater in size. And notice you can still see antral follicles kind of in the background there. And obviously in a natural cycle, you only release one egg at a time. So that's a good representation of that. So remember, in order to go from, so in a natural cycle, how you go from those pre-ovulatory follicles or your antral follicles to a pre-ovulatory follicle is really you have this process where you select a dominant follicle. So there is this complex process that your ovaries kind of duke it out, and the best follicle starts growing and becomes your dominant follicle. Remember, the reason we only have one dominant follicle that kind of takes over is because evolutionarily it's not to our advantage to have twins or triplets, because those are, or have a litter, because obviously those are more complicated, and evolutionarily it wasn't to our advantage. So it is to our advantage, though, to have a single dominant follicle, because that means that you're going to release one egg and have a higher likelihood of having one pregnancy or a singleton pregnancy. So there's that process where you get the selection of the dominant follicle. It's kind of like the mafia. Think of it like a monopoly, where one kind of takes charge and becomes the pre-ovulatory follicle. It gets large enough in size, and so then the next question is that how do you really detect ovulation? So For ovulation to occur, if you're checking your hormones, ovulation occurs after the estrogen has kind of peaked for 24 to 36 hours. So in theory, you have to have a sustained elevated estrogen for over 50 hours in order for you to cause an LH surge. So after that estradiol peaks, ovulation occurs about 10 to 12 hours after your LH peaks. So a lot of people ask about ovulation predictor kits, for example. So the way those work is that basically you buy them at the store, the same place where you buy a pregnancy test. And these are sticks that you start urinating on at the first void or the first urination of the morning. And so you urinate on the sticks and then you figure out whether, and it tells you whether you're surging or not surging. There are like a lot of different kits out there. So everyone kind of reads a little bit differently. So you have to kind of adjust the one you bought. But essentially that's how it works. And the whole point behind it is you're trying to detect when you're ovulating because it tells you when you're surging or you're in peak fertility or whatnot. And then you basically want to have timed intercourse 24 and 48 hours, after you first detect the surge, in order to try to capture that window of your ovulation. And remember, when we talk about natural conceptions, if you think about the extremes of natural conception, can occur from a single bout of intercourse 6 days prior to ovulation to 1 day after ovulation, because the sperm kind of hang around. And so not to say that you want to, have that extreme range of window, but just to kind of feel reassured that, if you're like an hour late, that's not going to be the reason why you don't get pregnant. So that's so this picture on the very top is kind of giving you a representation of how LH predictor kits work, or urinary predictor kits. So basically the way it works is that there's a basal level of LH, and then once your LH is above that certain range, then it'll tell you that it's positive. The one caveat to ovulation predictor kits is they're not 100%, and the patient population that tends to have the biggest problem with these predictor kits are the patients that have PCOS. So there are certain subset of patients with PCOS that have a basally elevated LH, and so theirs will always test positive, right? Because their LH is just naturally higher as part of their disease process. So ovulation predictor kits would not be accurate for them. So why is the LH surge really important? Well, it initiates the continuation of meiosis in the oocyte. So that's that process of that final maturation step for the egg. It also causes luteinization of the granulosa cells, which are kind of the supporting cells. So that basically transitions their production from estrogen to really producing more progesterone, which, remember, that's what's needed for the maturation of the lining of the uterus so that we can get implantation. It causes the expansion of the cumulus cells, which are the supporting cells, so that way that the sperm can kind of navigate through and get to the egg, and also so that it can get picked up by the fimbria from the fallopian tubes. And it also causes the synthesis of prostaglandin, which is important for follicular rupture. So this is actually really cool. So this is actually a laparoscopic representation or depiction of ovulation. So here you have this is one of the probes from the laparoscopy, but this is the ovary right here. What they're highlighting here is the follicle. This is called the sigma, which is basically that outpouching that is forming. And this right here is going to be the complex that's going to get picked up by the fimbriated ends of the fallopian tube. And remember, that's where we're hoping egg and sperm meet. So very fun. So again, we talked about what are different things that we can do to see if a woman's ovulating. Well, we talked about the ovulation predictor kit. There are some women who measure their basal body temperature. And essentially what happens is with rise in progesterone, you're going to see a slight elevation in core body temperature. So you're supposed to be measuring your core body temperature right, like first thing in the morning, right when you wake up. It's really hard to do. And I think that accuracy wise, I would say this is probably the lesser effective option, because sometimes it's easier to have like either a yes or no. And another thing that you can do maybe with your OBGYN is check like a day 21 progesterone. And if your progesterone's elevated or above 3, then likely you had ovulated. but that's kind of like a little after the fact, right? So, all right, so what happens kind of in the second phase of the menstrual cycle? Well, that's also important too. So in the luteal phase of the menstrual cycle, the corpus luteum is what was the dominant follicle. Remember, it now shifts function. So now its job is to produce progesterone to make sure that it can support an early pregnancy. So the corpus luteum secretes progesterone because it completes the preparation of the uterine lining, remember, getting it ready for implantation. It also secretes some estrogen as well, which works really well with progesterone and other important hormones. And remember, the corpus luteum is actually created pre-programmed to die. So it's programmed to regress unless it's rescued by HCG by an early pregnancy. And it has to get rescued by 9 to 13 days after ovulation. Otherwise, it's going to regress or die. And so remember, HCG, once someone's early pregnant and that HCG level starts to rise, that's really important because that's really what kind of rescues this corpus luteum and keeps it going and maintaining the important hormonal production until about 9 to 10 weeks of pregnancy, in which case the placenta starts taking over that function. So a lot of times we will provide some luteal phase support by giving you some extra progesterone, just in case you have a problem of your corpus luteum not producing enough progesterone, just to kind of help maintain that that early pregnancy. So alas, let's say, you don't get pregnant that month. So you get the demise of the corpus luteum because remember, no pregnancy has occurred. So that means it wasn't rescued by HCG. So that leads to a drop in your estrogen and progesterone because remember, that's what the corpus luteum produces. And so with that drop, then that negative feedback on your FSH is released. And so now FSH starts to rise. And then you get that rescuing or that recruitment of those 70-day-old follicles. Remember that have been growing. So they are rescued from atresia, which is cell death. And then you have that emergence of a dominant follicle again. So it's kind of like a little circle of life, if you will. All right, so how we kind of see this on ultrasound and what we're kind of looking for. So when you come in for a baseline ultrasound, especially in the beginning of a menstrual cycle or a treatment cycle, we're looking at the uterus here. So this is the fundus or the top of the uterus. This is leading towards the cervical end. This right here is your endometrium, which is the lining of your uterus. And so in the beginning or day 3 of your menstrual cycle, that's when you're usually on your cycle still. So it's nice and thin because you shed it. So you're shedding it actively. So it's nice and thin. So it's usually about 4 millimeters or so, sometimes a little bit thicker. And then when you look at your ovaries, this is the right ovary here. And so you see nice little antral follicles here. So I would be very pleased. This looks like a great ovarian reserve. And then we're looking at the left ovary here, and we have some antral follicles here as well. These are measuring about 2 to 10 millimeters in size. So we can do an antral follicular count of about 11 just based off of these two images here. So that looks like a good ovarian reserve. So this is your baseline ultrasound. This is, at the very beginning of a menstrual cycle. Then as you get closer to ovulation, how that changes is that you have your uterus here. So you have the fundus of your uterus or the top of the uterus here. Now look at your endometrium. See how that's different. So you have a nice plush endometrium here. This is a nice trilaminar or 3-line pattern. And you see the thickness of the lining of the uterus here is anywhere about like maybe greater than 8 to 10 millimeters. We can see sometimes even thicker than that, but at least greater than 8 millimeters is fantastic. And then again, we have a peri or pre-ovulatory follicle. So we have a dominant follicle here, usually measuring about 17 millimeters in size or greater. And we still see some antral follicles here, but remember in a natural cycle, you're more likely to get just one dominant follicle because it's going to suppress the other follicles from growing. So one of the things that we should kind of spend a little bit of time talking about is how some fertility treatments work, because I think that's kind of interesting. So our most common treatments that we do are basically geared towards overcoming that whole concept of a dominant follicle. So if you only release one egg, you only have one opportunity of pregnancy. But if I can get you to release more than one egg, then you now have multiple opportunities of pregnancy. So, the different ways that we can do that is we can do that through letrozole or Femera, Clomid or clomiphene citrate. Remember, for PCOS patients, Femera or letrozole has better literature to support a higher pregnancy rate in live birth. And then we can also do that through injectable gonadotropins like Follistim, Gonalef, and Menopur. These injectable gonadotropins are the same medications we use for IVF, but obviously if you're using them for like inseminations or something like that, you're using them at lower dosages. So you're not going to become hopefully the next K plus 8. So like how letrozole, for example, works is a selective aromatase inhibitor. So it's an anti-estrogen. So it decreases the ovarian estrogen production, and that estrogen actually negatively feeds back on FSH. So if you don't have as much estrogen, then your FSH can increase, your endogenous FSH can increase, and that's follicle stimulating hormone. So that leads to multiple follicle development. Clomid works in a very similar way, but basically Clomid is a selective estrogen receptor modulator. So that also inhibits estrogen receptors that are in your hypothalamus. So your brain doesn't perceive the estrogen that's actually circulating in your body. So that inhibits the negative feedback of estrogen on the gonadotropin release. So you actually secrete more FSH or follicle stimulating hormone, so same way. And that leads to multiple follicular development. And then to give injectable gonadotropins, that's just giving you exogenous gonadotropins that your brain would naturally make, but just at higher levels. So a little bit of quick facts. So when I ask you if you have a regular menstrual cycle, it doesn't have to be on the same day. It's actually really rare for it to be on the same day. So a typical menstrual cycle is about 28 days, and there's a 7-day grace period. So it can be as short as every 21 days or as long as every 35 days. And there's usually some variation to it. So as long as you typically get your menstrual cycle every month, then that's usually a good indication that you likely are ovulatory. The average length of a menstrual cycle is generally 7 days or less. If your menstrual cycles is a lot longer than that, then that's not normal, and we should probably work that up, or you should see your OBGYN and get do some investigation behind it. Another common question is, what's the average number of pads or tampons used per day? And typically it's about 3 to 6 pads or tampons. Now, obviously for some people, and like the first 2 days of your menstrual cycle may tend to be a little bit heavier, and then it kind of lightens up. So you kind of average it out and it's fine. But if you're going through like 9 or 10 fully saturated, you have a history of anemia or things like that. Again, another thing that I would probably bring up to your doc or an OBGYN and do a little investigation.